Welcome to ICE Webinars, a cool place for hot topics. ICE Magazine is proud to bring our monthly webinar series to the imaging industry. ICE is the community that directly links nearly 7,000 imaging professionals with a monthly magazine, online community, annual conference, and now a monthly webinar series. ICE Webinars would like to thank our sponsor, Technical Prospects. Technical Prospects is an industry-leading medical imaging parts, training, and support service provider. They provide the medical imaging industry with the highest level of QA-tested Siemens parts at significant cost savings compared to the OEM. Their medical imaging training program sets the standard with the only AMI-accredited training center in the world, offering 45 ACI CEUs per course. They also offer customers a 360-degree advantage surrounded by support. For more information, please visit technicalprospects.com. Today's webinar is eligible for one ARRT Category A, Continuing Education Credit by AHRA, and is approved for one CRA credit. You can obtain your CE certificate by completing the post-webinar survey. More details on this at the end of today's webinar. We're excited about today's presentation featuring Sam Darweesh. First, a few words from Andy Cluck. Andy, you may begin whenever you are ready.
All right, thank you, everyone. We're really happy to be a part of this today. As she said, I'm Andy Cluck. I'm the Digital Marketing Manager for Technical Prospects. As she said in her introduction, Technical Prospects has over 20 years of experience with Siemens Medical Imaging Solutions. We're an industry expert, and we have a lower DOA rate than the OEM. We provide quality tested and ISO certified parts through ISO 9001:2015, as well as ISO 13485:2016. So without further ado, I want to introduce today's awesome speaker we have lined up for you. Sam Darweesh will be presenting today. And Sam is an experienced CT and MRI senior engineer and subject matter expert. He has been in the medical imaging industry for over 20 years, working with industry-leading CT and MRI manufacturers, as well as major independent service organizations worldwide. Sam has extensive experience working in all aspects of medical imaging industry, including CT and MRI field engineering and level 3 lead technical support. He dedicated his time providing expert recommendations to his team of engineers in North and South America, and was also responsible for major strategic projects on CT and MRI systems worldwide. Sam is also an adjunct professor of medical imaging, providing focus on design and functional performance of medical equipment, as well as consistent image quality. Sam earned a bachelor's degree in electrical engineering and a master's degree from the University of Texas. So with that, Sam, I'd like to turn it over to you. We're excited to hear you talk today.
Thank you, Andy. I appreciate that. Hello, everybody. It's a beautiful day here in Appleton, Wisconsin. We're fortunate to be here and to continue to help the imaging industry worldwide as Technical Prospects continue to offer a continuous and dedicated educational program and continuous training academy. So today, I would like to speak about what's the approach to teach imaging engineers. What changed over the years? From the time we started imaging in the 70s until today, what's the overall change happening? How can we continue build? What's the requirement? What's the expectation? And what's the caveat? So together we'll navigate through the elements today to learn about the change in style of learning, what's the potential downtime of that change, comparison of the new model and old model, and a highlight of adult learning research that we have conducted. And then we'll introduce you to the cultivated new model of adult learning and its effectiveness through the Training Academy. So let's begin. So first, let's explore how has the style of learning changed over the years. We see that everybody now offering what I call the a la carte model. And to explain the a la carte model, let's visit its concept. It's pretty much means that you can pick any course you need, any course you want, without actually look at how that would fit for an adult learning model. So today's theory that an engineer can go to a 7-day system course and return capable to actually service the equipment. So an engineer, regardless their background, they would go to a 7 days CT school or MRI school or cath lab school, and then they become capable to actually take calls and service the systems. So is that the case? Is that true? Is 7 days is enough? We could say it's familiar, they could get familiar with the system. It's a familiarity education. But does it result in actual expert? Do they actually learn how to solve complex problem and how to function under pressure and how to actually be able to solve in a timely fashion? The question is 7 days enough? I would say it could be enough for a simple step up. Like if somebody knows a somatome sensation 16, they could become familiar with somatome sensation 64 with a newer image reconstruction, with a newer ultra-high resolution filter on the DMS. That's very possible. It's a one step up. But the bigger idea is it actually possible to just look at your imaging assets and decide to choose a course to send your engineer to based on what you have today in a hospital? That's what we are trying to explore. What are the potential issues by just choosing an a la carte model? So we find out through research there's the potential issues of sending an engineer to a one-time course 7 days and send him back to the field. That's we are actually inducing and contributing to the problem, because there will be a lot of examples that we captured based on an unintentional problem creating. When you know the system for just 7 days, then you definitely did not master everything about the system. So as you are working in a complex, highly digitalized equipments, like the capital equipment in hospitals, CT, MRs, X-ray, there are a lot into details in the troubleshooting that actually can't be captured in 7 days. So you could create more problems. That's what we have seen in the research we have conducted. We also noticed that we actually contribute to a longer downtime. What that mean? That means the system will remain down for a longer period, because actually the engineer will be, as he goes, troubleshooting using his definitely distinctive skills of troubleshooting, but at the same time trying to apply the methodology,
that he knows to this particular system, which is they are definitely different. In today's technology, it's very difficult to say CT is CT and MR is MR. Today, that stands as a misconception. We cannot send people for CT school just simply because they did CT 20 years ago. The continuum of learning will be missing. Having the capability to troubleshoot today's technology, it's required a support system around the engineer and not rather sending him to 7 days course. Beside that, that's for the veteran. They still need continuum of support. Now, for the younger engineers, people who've been in the industry for just a few years, that they are equally intelligent. However, sending them to a 7-day course and then send them to the field to face it all in an island, if you will, it will end up injecting a major lack of confidence for them. Those systems could bring a problem that humbling to a very seasoned, well-versed engineers. How about somebody who learned this for the last couple of months with 7 days of training? Adding to that, that's when we create lack of confidence in the adult learning model. We learn through research that we're actually creating bigger problems, and those problems could be permanent to some engineers. It's not easy to rebuild confidence once confidence breaks. It would take longer and longer time to actually recover. All that's from engineering perspective. Well, the reality, our research also highlighted an angle about today's expectations, where actually people seeing the engineer should be. From hospital administration to radiology to biomed leader, the notion is that over time, because of the technology, when we collect inputs, everybody thinks that today's advanced technology should be more intuitive to the adult learning. And that's what we call it technology trained misconception, because pretty much if we have access to iPhones and PlayStations and so on and so forth, and the kids getting into technology early on, that doesn't advance them to be able to actually solve complex engineering problem. So having access in technology and its application in day-to-day application on life, it doesn't actually come with an advantage to understand complex technology. Another expectation today is like one course is enough. People can do simply one course and they will be good to go. While the reality, it's just not possible because of the way that the emergent learning, if you will, the actual support system around the engineers need to be in order to hone and develop, as we can learn later in this presentation. As for the uptime, the systems are faster, so they scan more patients per day than before. So when the system is down for a day, everybody's seeing the difference. That's how the notion of uptime started 14 years ago. It started because now it makes a big difference when an ERCT is down. It makes a big difference when we have a certain surgery scheduled and our cath lab goes down for certain cardiothoracic needs. So the uptime become very essential. And from radiological perspective, I won't blame director of radiologies or even radiologists when they believe 98 is not enough. Systems has to function at 99. But I believe our job as engineers is to see what it takes to ensure systems function at 99. What kind of support we then need to provide our frontline, our field responders, in order to be able to achieve that 98 or even 99%. I often talk about support system for engineers and not to let them go on an island, not to let them go alone. Misconception of that, it could be too expensive to actually affiliate an engineer with a training academy. However, the reality is, with the proper scale, it's very doable to do so. Let's take a second and reflect on the old learning, the old model, or as we all call it, the good old days. After we learned about the newer a la carte model, the fast-paced, we're fast, we can achieve everything fast, we can learn CT fast, we can go to a 7-day school and be good to go, and we can troubleshoot complex problems, and we can be in a frontline alone. Let's look at the good old model. And I can't resist to mention it's actually featuring a picture of our founders that we live and translate his vision every single day. Mr. Bob Probst, who brought up this establishment to life through his vision. He's an ex-Siemens engineer who had dreamed that he could build something, not just to provide parts or training or service, but to create a long-lasting impact in healthcare. My old friend Bob influenced me, influenced many others in this industry to do things right, consistent with high level of excellence. We learned from him a lot about how much honing needed to build a robust engineer. So Bob in that picture, standing on the left, he actually installing one of the first CTs in the United States. And we learned as we interviewed Bob and other industry influencers that is actually used to take 3 months of education to learn the basics. And they would send the engineer to a system course for 6 weeks. And then they go back to the field and shadowing veteran engineers for a long period of time. And then at that time, they will send them back to advanced course for 3 months. At that time, people look to the imaging engineer, to the biomed, to the people working in hospital like, wow, these guys, they do possess a certain level of knowledge. They're actually well admired and they do hard work. Everybody felt that the engineers are actually doing their best and that there's no expectation beside that the engineer would do everything they can. The uptime might have little to no expectation. The expectation of uptime at that time was, you're going to do your best to get the system up. Okay, we believe that you're going to open the wiring diagram, you're going to read. That's a liability nowadays if the engineer reads on site. With all that, the technology was slower. So you could produce fewer scans per day. And at the same time, be able to stay without scanner for a couple of days if needed, waiting for parts or waiting for the engineer to troubleshoot. That's the old training model. We spend months of training. The lifestyle allowed that too. I'm not sure it does today for the engineers. So we went from months of training and less expectation to 5 business days, 7 days of training and a lot of expectation. That's by evaluating and speaking to industry experts, learning more about the required learning for imaging engineer to obtain knowledge. So we had to do something. We had to leave the engineering industry and go ask somebody else. Is the adult learning change in your arena too? That was the question. Is the adult learning now taking away less time? So we have picked 2 equally complex paradigms, medicine and classical music. We wanted to actually look at rigor and creativity, which the reality the engineer do possess both and apply both on daily basis. The complex thinking, the rigorous approach to problem solving, the capability to navigate multiple frameworks and multiple flowcharts at the same time, as well as being very creative in the way you navigate all this. Just like a musician do to an etude or an orchestra music. So our pick was to ask a physician who've been in actual medical school education for a very long time as a professor. What happened to the adult learning over the last 2 decades? Did we get smarter? Is the engineers the only one who have to modify their education learning, or the physicians as well? The answer was physicians' education never changed. With all the technology, with all the advanced medical equipments, with all the WebMD and Google and wherever you want to say to navigate their medical problems. Matter of fact, if you Google a medical problem or a medical condition, you'll have a better luck finding a lot of data on Google and WebMD than when you Google an actual MRI image quality problem. You won't find anything. If you want to find out how to solve a certain echoing or spin echo or triple artifacts or any of the things that you have to actually have a certain connection to certain depth of knowledge of certain people that you can learn about it. So professor of medicine confirmed that physician education in adult learning never changed. It remains to be 8 years of education. Is that years of on-job training required? I asked, is the internship changed? Sam, it's still the same 2 years. I said, is the residency program changed? They said the residency program remained the same. There's nothing changed in that arena. So we know for physician, their learning is still the same. So that adult model never changed. Now we ask for musicians, and by musicians, I mean classical musicians, people who plays violin, viola, cello. And I asked a professor of music at UCSD, University of California, San Diego, and I said, Professor, how is the adult learning to that matter? Is it changed? I'm making a correlation in engineering learning, and sure enough, it was 8 months. Now we are correlating to a 1 week What happened to playing a duet of Mozart's or playing the third orchestra in G major for Beethoven? Now if they start, are they going to be able to play such rigorous and creative pieces and hit every flat and every sharp and every E major and every G major the way they should? They said nothing changed, Sam. It's still the same 6 months milestone before they be able to provide the right pitch and play on the proper tempo and actually conduct the proper rhythm. Same learning process, same consistency. It still take years of practice and education. So with that, we back to the imaging engineer. Now we know that the population, especially those that are complex ones, they actually do not have a problem with learning. They still follow the same learning pattern. So how are we going to solve our problem from 6 months to 9 months of training all the way to 7 days? We find out that in order to solve this equation, and especially even if healthcare systems are willing to send their engineers to months of training, the engineers at this stage is not able to because of the lifestyle and responsibilities. That's when the emergent learning come into account. The share of the continuum of knowledge. That's where we incepted what we call the Training Academy. The Training Academy is an emergent learning approach in which we put the engineer through a series, a subscribed series of educational events. It all starts by an actual screening to understand the strength, the weaknesses, the opportunity analysis of the individual. Then after that, we start customize a solution to help that individual build their knowledge. We use workshops, we use interactive training so they can be anywhere around the world, yet they still able to access our platform, our learning platform. We provide on-job training and we send actual product support specialists and national tech support engineers to the field to help with that. And of course, we still have our system courses. We still offer the a la carte for a reason that if somebody knows a Sensation 16 and want to step up, that's available. But to build a continuum of knowledge, the approach is actually to follow what we call the Training Academy path or the emergent learning. The academy built on certain aspects, built on creating a secure base for the engineers. The engineer is no longer functioning in an island when he is in a hospital. He could go at the academy to 1 week course, go back to the field. But the minute he has a problem, he have a designated mentor to talk to. That mentor will be able to actually provide the guidance, immediately enable what we call advanced troubleshooting. Through a certain app from the engineer phone, we are linked with him on site to the system, and we are actually troubleshooting live. The engineer is on point to troubleshoot because he have a secure base. He have a whole database and a whole actual training academy. at his fingertips. Pretty much, our national tech support team received over 300 calls of hard down a month as we do tech support. And per modality, 300 call MR, 300 call CT. So the number of frameworks and scenarios that they retain and they have in the database is endless. Pretty much if we artificially intelligent that database, it could solve any CT or MR problem. That's how the engineers in the field will get the quick support that practically decrease the downtime. Boost the confidence for that engineer because he's the frontline guy. He's the one who solved the problem. And then 50,000 parts in stock. The Academy connected immediately to our inventory and can guide and provide direction about what part to ship, what method of shipment, how fast needs to get there. And it will integrate with the operational team on the ground to provide another part of support for the engineer. So having that, I would say, ecosystem built around the engineer. You get the right education, you get the 24/7 life support, you actually have a mentor who actually look for your development, that you can be anywhere and access it through our interactive virtual training academy, that you actually can set workshops with your mentor to plan for a big shimming coming or to plan for a cold head replacement and learn cryogenics. The more you are plugged in to the system, the more you are connected with the rest of the team, the more you actually support it. You're a part of a big support network. With all that, checks and balances remain essential. As a chairman of engineering, following and translating the vision of our CEO, Jeremy Probst, who's an engineer, as well as the son of our founder, who lived this vision, lived the commitment to excellence, I would say since his teenage years, for the last 25 years. The commitment to excellence remain alive. I yet remember that the first day I joined and assumed office at Technical Prospect as a chairman of engineering, Jeremy made it clear that's at the top of our priorities is maintaining the quality. And when we are creating an emerging learning academy to all engineers worldwide, with that level of dynamics, we're going to need a third eye. We're going to need a certain lens that govern our quality. His words, and I was planning a trip. So it was like 7 minutes before I run to the airport. He said, I need you real fast. I'm going to need you to design the whole system based on 2 quality aspects. More refined ISO, which is we already were at ISO at that time. And I want all the training to be AMI certified. The uniqueness of AMI certification hold us on a very high standards. So when we create the immersion learning, when we are creating those workshops, when we are working on details of the courses and try to build that knowledge platform for the engineer, this is also supervised and watched by the AMI certification committee, by the ACI accreditation. Everything we do, we actually submit it. And that put us at the far front to serve our engineers anywhere they are. By being AMI certified, we definitely held the standards. And by being ISO 13485, it put our parts, it put our processes our commitment to quality, our commitment to safety on check every day, because everything is mapped out and we function within certain frameworks. The power of the training academy is beyond the focus of learning. Today, we look at the academy as a place for those who subscribe to the model, as a place focused on not only the learning, but the development of the support network and team. You gain speed not by learning and engineer weaknesses and then through them in the field, is by learning and engineer weaknesses and work on how to mitigate those weaknesses and how to maximize on their strengths. It's how you avoid creating errors. This is how you avoid a poor quality outcome. That your engineer in your in-house program, your biomed, regardless where they are, they're going to be part of a cohesive team, function with confidence because they have a secure base. They know that's at their fingertips. They are true experts in the imaging services, or our instructors are actually AMI certified instructors. We found the best effort applied every single day in the training academy is to enable the in-house program. For years been thought that the in-house program may have limitation in what they can fix. With the academy model, with the emergent learning, the in-house program been empowered. And we have several healthcare systems with us that showing over $700,000 cost saving and very engaged engineers annually, investing in engineers' knowledge, not just save you money in the service of your medical assets, but maximize their retention because they are supported. You're lifted the pressure on them and you're continually investing in their learning. You could also use the academy to branch out, to map your own customized solution. And that would involve actually plan to how many engineers you need. Do your labor utilization. Do the characterization of learning based on strength analysis, cultural index analysis. Understand how each individual can fit to certain role, who actually the best fit to be a CT engineer, who's actually the best fit to be an MR engineer. How we choose those engineers, where the rigors and the long hours matter. The overall system depend on the right choice, the right selection to push it through the immersion learning platform. Today, the Training Academy works with healthcare organization, imaging centers, and the expert work paid off every day as we see the individuals we support in the field excelling and improving in everything they do. I will pause here and I would love to take any question you may have.
Thank you so much, Sam, for this valuable information. As a reminder to our audience, if you do have a question for Sam, please use the questions feature on the webinar dashboard. We do have some questions that have come in already, Sam. The first is it possible for a biomed technician to become an imaging engineer? And what is the training needed?
Well, that's that question actually at the core of what we are explaining. It's a great question. It's pretty much very possible for an imaging engineer to become for a biomed engineer to become an imaging engineer. Matter of fact, I see a lot of benefits by doing that. Biomed engineers, they're really vested in their healthcare system. They are the one who work long hours. So the dedication, the attachment to the mission, it's already there. Once the fulfillment is there, the rest is easy. As for the knowledge retention, it's very possible if you put a biomed engineer through the actual immersion learning. He's taken essential courses. He's doing the screening, evaluate his capability, and then put him in the right customized path in order to build his knowledge and put him in the field. He would utilize that training. He would utilize the tech support. And by doing that, his knowledge elevated, and slowly but surely, he's moving from one point to the other. I would provide some sneak peek about research that Engineering Oversight Committee doing at Technical Prospects, that a research about which modality to start for biomed. And the answer will be revealed in the first quarter next year. They actually brand new equipments. This is not legacy equipment. Those are equipment 23 years old, been purchased by Technical Prospect to create what we call imaging suite. That's coming into implementation first quarter next year, and that will be really where the biomed engineers need to watch how they would transform in a immersion learning environment all the skills and knowledge and troubleshooting technique they have from biomed to imaging.
All right, our next question is, we have a mixture of imaging equipment. We have new equipment that continues to be added and old equipment that still needs to be serviced. When we add a new engineer, should we train them on the new equipment or the old equipment?
That's another great question. That actually where the immersion learning comes into account. I believe what we are doing today is most effective because we are taking both under consideration. It is not an a la carte. It is not you have to pick one. Rather, in the training academy, we know the old equipments are actually workhorses. They're legacy equipment. They're designed to work 20 years. While we have a newer system that's there, as I explained, they are extremely different in their technology. If you teach your guys just the new equipment, their troubleshooting depth will remain limited, and they will never touch the systems, the old systems that they're going to work for a very long time. If you teach your guys the old equipment, then they will be falling behind, and that's even impacting their retention because pretty much somebody else will offer them a job with the newer equipment learning. So the training academy is pretty much create the balance. It gives both world on a certain depth on each one. And then you supplement in the older equipment, you will learn a certain level of troubleshooting for older equipment, and you are supplemented with tech support, proper level of tech support. And then you learn the new equipment and you are supported with tech support and workshops to hone the knowledge, because we know that you're going to work with the newer equipment longer as the years advance. So the answer is to create a mix of both through customization.
Our next question is, as we move toward in-house programs, is there a way to determine how many imaging engineers we need and the required training?
That's a great question. Part of the services that we offer is labor utilization analysis. And pretty much it starts with understanding first the patient flow in the hospital, the ancillary services, the imaging department, their actual coverage period. And then once we understand what I call the clinical parameters of a healthcare system, then we will switch to analyze the existed imaging capabilities. And based on that, we would see what they have. If they have all biomedical or laboratory or some imaging, we would start decide based on that the ratio of added employees. It's not all the time adding more labor is a good thing because you're gonna have to think heavily on assimilation. Sometimes using your existed guys and provide the right support and the right knowledge and get them going, and then you would add more people is more valuable. So we work with academic healthcare centers. We were affiliated with several worldwide academic healthcare center that we help with really utilization analysis of their labor. And the answer would be it's customized based on the patient flow and the need, and it's highly advisable not to inject high numbers of imaging engineers into a healthcare system without thinking of how you would assimilate them and how you would take care of the existed talent as well.
Thank you again, Sam, for your time today and for a great presentation. I would like to encourage everyone to visit today's sponsor to learn more about the services they provide to our industry. Please visit technicalprospects.com. As a reminder, you can obtain your continuing education certificate by completing today's post-webinar survey. The survey will be emailed to you 1 hour after the end of today's webinar. You must complete the survey to receive your certificate. You'll be able to download your certificate as soon as you submit your survey. If you have any questions, please reach us at webinar@mdpublishing.com. ICE Magazine is proud to bring you our monthly webinar series. Thank you for being part of the ICE community. For more information about our upcoming ICE webinars, please visit icewebinars.live. Thank you all and have a fantastic afternoon.